Okay, so, but we've got to get everyone familiar with the stuff too. I am a sleep specialist. I'm double board certified in sleep disorders. I've been doing dental appliance therapy for just under 20 years. I actually fit devices. I've had a dentist in our office for many, many years. He's done a lot more sleep than he ever thought he would do. I do a lot more dental sleep medicine than I thought we did, because we're a hybrid. So it's a very unique situation. You won't see any other sleep specialists in the country that do that.
Right.
I also am an inventor. I've invented a couple of dental devices. One is Medicare approved, the other, and then two of them are FDA approved. So I'm very immersed in dental appliance therapy. I'm a champion for oral appliance therapies. I don't think most physicians or sleep doctors will have the time or the compulsion to do what I did. So I just know that that's a way that I can see this from that vantage point, because I'm a champion for the dentist. I know how much work it is for the dentist and the dental team to manage this. You know, I used to have, before I retired, 5 dental techs that were doing stuff that I've trained on the job. And we had our own integrated dental laboratory. We were the first office in the country to get home testing covered for sleep apnea screening back in 2005. So we've been doing this for a long time. We've been training offices for many, many years. And I took a hiatus from it just because I was so busy with my own practice. But now that I've got time on my hands and realizing that there's still a lot of people that need a champion for their team, I'm more than willing to put my time into this to help you guys become successful too.
Joe's in your corner. So Joe,
yeah,
before you start your PowerPoint presentation, just let them know kind of like what happened in your practice in Portland. I mean, if you feel comfortable.
Oh, I mean, I could. Basically, we were one of the largest dental sleep medicine practices that I'm aware of in the country, because we had everything integrated.
Yeah.
I was doing consulting. I was writing the prescriptions.
Yeah.
Our team was doing the appliance therapies. We were very focused on all therapies, but because there's such a large hole, a gap of therapy being provided for oral appliances, we did mostly oral appliances and a little bit of CPAP, and a fair number of what we call combination or hybrid therapies. So say the dental appliances and the patient's happier, but you treat them and then you test them and they're not safe. There's still enough sleep apnea left over with the device being in place. Well, then you need to ask them to consider combining therapies. And so since CPAP, the major problem with CPAP is that the pressure can be too high and uncomfortable, or the mask can be moving around a lot, or you can have your mouth open and you bleed air out your mouth, and those could be the problems with CPAP. We would get them back onto CPAP at a much lower pressure with the current dental appliance, and then get a lot of people to be able to tolerate CPAP that never could tolerate it before, right, because the pressure was too high. So that's, again, what I'm condoning is dental appliance therapy as the primary treatment for, especially for mild and moderate sleep apnea patients, and keep that as a close second option for patients who are severe and can't tolerate CPAP.
Yeah, let me just say something about that, too, Joe. So the statistics out there saying that the CPAP is the gold standard is still true. CPAP is more likely to get people under the AHI of 5 than an oral appliance is. But the problem with compliance, and Joe is talking about combination therapy, our program is really strong in that. But their definition of success is 4 hours of wear per night, 3 to 4 days per week. That's pretty dismal. And if you consider compliance, we have much higher compliance with oral appliances. If you put the two together and compare apples to apples as far as outcomes for sleep apnea effectiveness, oral appliances are about 51%, CPAP 50%. So we have no reason to consider ourselves inferior in this area of care. Okay, none. We are helping patients. And with the combination therapies that Joe is talking about, where you combine oral appliances, EPAP appliances, positional therapy, and that with CPAP, so that you can tolerate the CPAPs or even go into oral appliances and EPAP alone, I think we have a superior program. Thanks.
Yeah, so what I put together today based on our conversation
Go ahead,
was
Joe. I'm gonna give you control on that. And why don't you go ahead and share your screen? I'm gonna make it a presenter screen.
okay.
And go ahead and do
But and first and foremost, it sounds like we have a team that's finally getting in stride post COVID, and everyone's kind of wanting to come together and become more of on one page here. So I'm going to try to bring everyone on one page so we all have a level playing field of information that we're going to make our decisions by, and then that will help you build off of this going forward. And it does sound like there is a sleep doctor in St. Vincent's, if I'm correct, that I heard. But the problem, I think, in the area is it's a smaller community, and as far as I was informed, it's mostly in-lab testing. That will be a deterrent. It'll inhibit you from being able to maintain as much of a screening and successful delivery of treatment as you're going to want. And so this practice is definitely going to have to integrate into some sort of home testing protocol to help speed this up. And we'll talk about that a little bit later.
Yeah, good.
And this is very common. I mean, trust me, I'm seeing this all over the country. I'm talking to dental sleep medicine providers who've been doing this for over a decade and are board certified, and they're still frustrated because they only get a very small grouping of patients.
One of our new members is mentioning that. She's board certified in Ohio, and yet she's having very few patients. And so she wants to join and find a way to get around these roadblocks. So this is good. Go ahead, Joe.
Okay, it says host disabled participant screen sharing.
Oh, shoot. I didn't know that. So let me just go ahead and fix that for you. Make co-host. How's that sound?
Let's try that. I'm going to go ahead and share screen again. There we go. And just for everyone's information, this is all being recorded.
Yep.
So I don't need that. Okay, I'm going to go to slideshow here. Okay, so can everyone see the screen okay?
Yep, I can see it.
And can everyone hear us okay?
Yes.
All right, great. So I labeled this Introduction to Dental Sleep Medicine for the Dental Team. And again, we're going to kind of just save probably questions until later, unless it's really burdened someone's need to talk about it. So just let me know. So you have to know that our SRBD is an abbreviation you'll hear a lot called sleep-related breathing disorder. And this is a spectrum of where sleep-related breathing disorders occur. I don't know, can everyone see my arrow here at all?
Yes.
Yeah.
So if you don't make any noise, you're a normal breather, everything's good, your oxygen levels are great, your sleep's gonna be great, you're gonna be in great shape as long as you're not stressed out from COVID making your life crazy. Primary snoring is a very, very light snoring that doesn't bother anybody. It's that cute little snore of your sweetie when you're first married and all you hear is a little, that's cute snoring. That's not gonna hurt anybody. And it doesn't bug anybody, that doesn't bother anybody.
Yeah.
Then you go to upper airways resistance, which is basically if you took a coffee straw, a stir straw, and you breathe through it, there's a lot of effort to pull in and out. Your oxygen levels will stay normal, but if you try it, you won't want to do it after about a minute. You'll say, this is really sucky. I don't like breathing through a coffee straw, okay? And that actually starts to make a noise. And I've mimicked snoring for a long time, so I probably will be able to go through a lot of these snoring things for you. So it's still annoying. So it's more of an extracted sort of noise. It's a no one's stopping breathing, but you hear it and you're like, ugh, I don't like that. Well, if you hear that loud of snoring, you can pretty much guarantee there is a level of sleep disordered breathing going on that could be treated and help everyone sleep better, including the person listening to it, okay? It's not really well covered by insurance. It's not really well regarded by insurance companies, but it is a disorder. And it's very likely going to be treated with a dental appliance in a dental practice. There's hypopnea disorders, and then there's OSA, okay? And then Pickwickian is that disorder where you're so overweight that all the fat tissue kind of squeezes on your lung tissue, your diaphragm, your airway is so tight because your neck's so big that you just cannot breathe. And so you're constantly tired and you're not able to get oxygen levels even equalized when you're awake. So you have a high level of carbon dioxide. So forget Pickwickian and focus on OSA, okay? OSA is a very fancy way. It's obstructive, meaning you suck your throat closed. Sleep apnea. Apnea means throat closure. Hypopnea means partial closure. So if you're going to do sleep apnea, you have to know those two terms. Apnea is full closure of the throat. There's no oxygen, no air going through. Hypopnea is a almost full closure of the throat, but there's still a little creep of air going through there, but your oxygen levels are dropping, okay? Apnea is a fancy word for suffocating, okay? So if you're sleep suffocating, whether it's mild, moderate, or severe, you don't want that. I don't want that. I've got mild sleep suffocating and I've worn a dental appliance for over 15 years. I feel better and I don't even snore that much. I almost have more like the little cute snoring. Not quite, but it's not as bad as some snoring. So, so there's mild, moderate, and severe cases of OSA. This is the long, lengthy terminology screen that's going to talk to you about the basics. We're going to keep rehashing this. So if you get this slide down, you'll understand this from this point forward. There are 5 or more obstructive respiratory events. A respiratory event is another sort of terminology for apnea or hypopnea. And it's per hour, and it has to result in certain number of symptoms, okay? If you have a mild case of sleep apnea, it's not considered apnea unless you actually have symptoms. And here's some of the symptoms. You're sleepy, you're falling asleep in a meeting or at a stoplight or a stop sign. You feel fatigued in the head and it's hard for you to feel energetic, or you're having insomnia. Either you can't get to sleep or you wake up frequently throughout the night can be symptoms to sleep apnea. Waking up breath holding, like you woke up gasping, which is rare. Remember, if someone's waking up gasping, it's very late in the disorder. It's probably 10 or 15 years after they've been dealing with sleep apnea, we're unaware of it. So that's rare to hear unless someone's got a very significant problem. Most folks will be like, I don't have any problems. And then their bed partner's going, they got problems. So just know that this is very rare to hear unless it's more severe. Habitual snoring. If you snore most nights, you very likely have sleep apnea. Hypertension, if you have high blood pressure, depression, if you're having ADHD symptoms, if you have a history of heart disease, stroke, a lot of cardiovascular connections, because if you don't breathe oxygen, your cardiovascular system breaks down faster. And that's the only connection here. If you're suffocating, your heart doesn't do well over time. It's amazing though, because the average person takes 10 or 15 years from when the symptoms started till they're actually diagnosed. So it shows you how tough we are. We're dealing with this over time, but then we start showing all these symptoms because no one's talked to us about it. So it's really, really important that we do. There are 15 or more events per hour. That's now moderate or higher. And remember, the apnea-hypopnea index is a combination of how many apneas we counted, how many hypopneas for the whole night, and then we divide that by how many hours you slept. And that gives us an index, a per hour index. And I'll talk to you about that. Respiratory disturbance index is apneas, hypopneas. And remember I told you about the UARS? Well, we score that with adding RERAs, which is that coffee straw breathing through it. Okay, that's a RERA. So apnea is full closure throat, hypopnea is almost full closure, and a RERA is a tight enough airway that's uncomfortable and you're sucking through that straw, but still maintaining your oxygen level. So it's kind of a spectrum like I showed you. So remember this. If you remember this criteria, you'll be pretty solid in your understanding of sleep apnea. The American Academy of Sleep Medicine is the AASM. They're the ones that put out all the guidelines together initially. If you're a normal breather, you have less than 5 apneas or hypopneas per hour. That's your AHI you can see here. But you can still snore. You still have upper airways resistance. You may still have to treat it, but you're very unlikely to have the cardiovascular problems that people will have with the moderate and severe. So mild is 5 to 15. That's mild. It could be snoring. It could be annoying. It can make someone tired, but it may not actually contribute to cardiovascular issues, at least initially, unless you have some genetic predispositions or other comorbidities. Moderate is 15 to 30 times per hour. So remember, 30 times an hour, that's it's every 2 minutes that you're not breathing, okay? And then above 30 is severe sleep apnea. So again, that's 2 minutes, every 2 minutes you're not breathing or more. And that's not a very fun experience if you ever tried that while you're awake. So what is an apnea? Let's look at this. This is a polysomnogram. It shows us a lot of the data that we collect from an in-lab test. This is overkill. Most of us who are looking for sleep apnea don't need all of this data. What you do need is you need to look at your oxygen levels, which is this little area here. And right now, as you're awake, this should be a nice straight line. You should not see these waves like the sea here. That's very scary to see your oxygen levels dip down, and then you have to recover and then dip down and recover. This is someone who sucked their throat closed and was not breathing for probably, it looks like 30 seconds. And then their brain says, you got to do something. Either you die or you wake up, and then you wake up and you start gasping a breath, but it's such a short period of time, only about 20 seconds, that you don't remember it. And then you ease back into some sleep, and then you suck your throat closed again, and then it repeats all over again, okay? So this is airflow, this is oxygen levels. We don't want to see your oxygen levels dropping into the 80s. So that's what apnea is. This is a very well-known video that was, that anyone who pays for sleep multimedia training resource will have access to. This is a fella, this whole time he's asleep. Even though it looks like at times he's awake, he's asleep. He doesn't remember any of this happening. This is exactly what a bad apnea looks like. So he just woke up from an apnea. Technically, because he doesn't remember it. It's called an arousal. If you look like you're awake but you don't remember it, it's an arousal. Okay, if you remembered it in the morning, if you woke up for 30, 40 seconds, it's an awakening. Now look immediately at his abdomen. His throat is closed right now. He's trying to breathe actively, but his throat's closed. You can see he's jutting his jaw forward because he's trying to get his jaw open, but the muscles are so relaxed he can't. And he continues to struggle to try to force with his diaphragm to breath past his throat, but it's not happening. It's not happening. Keeps trying. And then now, after his oxygen levels drop dramatically, he's gassed himself back to some oxygen, and then very quickly will start to close his throat again and go back into the apnea. Okay, that does not look like a fun time at all. That's a severe case. But that fella didn't know what was going on. You'd ask him in the morning, how'd you sleep? He'd say, yeah, I slept great, because it's such a short window of arousal that you're not able to remember that occurrence, but it doesn't look like fun. So since home sleep testing is kind of the major area that I think dental sleep medicine is going to be able to reach stride, these are some common ones that we're familiar with. Scott, do you guys have any home tests in the office yet?
No.
Okay, so you don't necessarily have to have a home test. Luckily, with Dr. Downs' online home sleep study.
I actually have two. I have this one here to offer, and I have this one here to offer, and also have a MediBite Junior and a MediBite. Yeah. So we have four different kinds.
There's 4 different types that we can actually deliver to you, and there's a couple of these companies that we could actually have them send it to you. And again, our team's going to offer the interpretation, so now you have the medical oversight to do this. Yeah. And if someone ends up doing this in the practice, we can also train them on this whole process too. But just know that home testing looks a little different than that video I showed you last time, which was actually an in-lab test. There's less to it. Like Dr. Downs was saying, this is a ResMed Air. This is a Respironics. This is an Aries, and this is a WatchPad. They all tell us what your apnea-hypopnea score is, what your oxygen levels are, what your snoring is, and what your body position looks like. Some of them will tell you sleep. This actually gives you an EEG here, but they're all pretty easy to take it home to screen and find out what's going on. So we've been looking at sleep apnea's effect on general health for many, many years. And now we know that common symptoms that we don't associate yet with sleep apnea or sleep suffocation or sleep deprivation related to sleep breathing problems are a long list of issues here. Depression, memory issues, irritability. And that's actually the most sensitive sign of sleep deprivation is someone's irritable. That's actually the most sensitive sign, not sleepiness, but agitation. Headache syndromes, restless sleep or fidgetiness at nighttime, a daytime sleepiness, snoring, dry mouth. If someone's complaining of dry mouth and you're seeing gum issues, it's probably due to mouth breathing at nighttime. And of course, we now know that almost 50% of ADHD symptoms are related to sleep apnea and poor sleep. Alzheimer's is a very, very close connection with sleep apnea and sleep problems. Depression, stroke, type 2 diabetes, almost 3/4 of type 2 diabetes patients have sleep apnea contributing to the problem. Almost 3/4 of heart failure patients. If a patient's on 2 or more blood pressure medications and they're still not 120/80, very likely sleep apnea is contributing to the hypertension or the high blood pressure, and that's almost 85%. Heart attack, stroke, and even heartburn or gastroesophageal reflux disease. And almost 80% of patients over a body mass index of 35. So remember, our body mass charts are our best predictors for a problem. I am only like 21% body fat. I have that long facial type of the kid who had allergies, a mouth breather, tonsil problems, ear problems, nasal issues, allergies, asthma. Those type of people will develop sleep apnea at even a normal weight because of the airway becoming more crowded due to not having ability to nasal breathe while you're sleeping. So just know that there are a lot of us who need airway help, but a lot of us are also compounding that by the obesity epidemic. Mm-hmm. So in your office, in every office, if you utilize screening questionnaires, you can formalize your process in the practice. So Epworth Sleepiness Scale, everyone's familiar with if you do sleep medicine. The Stop Bang screener is a very popular screener for sleep apnea, things you can do in the dental chair. Berlin questionnaire gives you more of an information behind everything. It's been researched, but we don't use it often because there's a lot of parts to it. So you can go to the National Sleep Foundation or hypersomnolence.com and get a free Epworth form like you see here. Basically, you want to ask the patient to answer these questions when they're in a non-caffeinated manner. Okay, so most people will make this decision based on how they felt after they had their cups of coffee. This is without the help of the coffee. Okay.
Yep.
Oh, by the way, the most commonly used medication in the world is caffeine.
Yeah.
Okay, no one's prescribing it, but it's the most commonly used medication. If you have 0 chance of falling asleep or dozing in this situation, you put a 0. If you have a slight chance, it's a 1. If it's a moderate chance, it's a 2. If it's a very high chance you're going to knock out and get sleepy, it's a 3. So what you do is just they read these questions. Okay, sitting and reading, what's my chance of falling asleep? Watching TV, sitting in a public place like a theater. Am I a passenger in the car? Lying down in the afternoon, sitting and talking to someone, sitting quietly after lunch without alcohol. That's important because alcohol can make things worse. Or I'm in a car while stopped as a driver, okay? So if you add all these up, the worst score you can get is 24, all right? Normal is considered anywhere between 0 and 10. I think 8 or higher is a little bit mildly abnormal. For insurances, usually it's greater than 10. So 11 or greater is going to be considered pathologic enough sleepiness to actually be considered a problem when you submit this. And then if you're above 16, you are like a narcolepsy patient. And if you're not familiar with narcolepsy is the primary sleepiness disorder where you actually fall asleep involuntarily.
By the way, I just wanted to welcome Kendra Sellers to the group today. So she's on now.
Oh, great.
Say hi, Kendra.
Hello. Good morning.
Good morning.
We'll get to some of the things you need to address in a little bit here, okay?
Yeah.
Sure. Yep. I'll just listen in until then.
Great. So the Stop Bang is just the first letters of each issue that you're looking for: snoring, tiredness, observed apneas, blood pressure, body mass index, age, neck, and gender are very highly sensitive findings. And if you remember this one questionnaire, you're going to be very successful at finding sleep apnea in the practice. So if you were to give this like the ADA recommends to every patient, then you're going to be able to find a lot of folks without even working that hard at it. So number one, do you snore loudly? So louder than talking, or loud enough to be heard through closed doors. That's pretty loud snoring. Or enough that your bed partner looks at you like, yeah, you snore. Do you often feel tired, fatigued, or sleepy during the day? And these are yes or no answers. Has anyone observed you stop breathing during your sleep? So you have to ask about the bed partner. Do you have, or are you being treated for high blood pressure? And everyone's got these little graphs that show height and weight, and you converge them together, it gives you a body mass index. If your body mass index is greater than 35, that's a yes. Now 30 is also higher risk. So if you're above 30, it's about a 50% chance of apnea all by itself. If you're above 35, it's about 75% chance. So literally 3/4 of people who have a BMI over 35 likely have a breathing problem. Age over 50. As you get older, your muscles get looser and you're a little bit heavier than you were when you're in your 20s. And so those things add together and it increases your likelihood for sleep apnea. So if you're treating anybody above 50, that also increases the likelihood that they have an airway problem. If the neck circumference is greater than 16 inches, especially in women, 17 inches is definitely a slam dunk for men, but in general, 16 inches is a general parameter. And are you male? So if you're male, you're twice as likely before the age of 60 to have sleep apnea. But once you get to about 55, 60 in females catch up due to menopause. Estrogen no longer protects you because it's not there anymore, or at the levels that you need it to be helpful in the sleep apnea conversation. So if you have yeses to 5 to 8 of these, it's a very high risk. If you have yeses to 3 or 4 of these, it's an intermediate risk, which means if from intermediate to high, you should be actually screening them with a study. If it's low risk, you can feel comfortable that you did your job and you screened them and no one's going to get on your case. This is the way you would measure a neck circumference. Use a tape measure. Greater than 16 inches in women, greater than 17 inches in males is a higher risk. So remember, if your body mass index is 35 or greater and you have one of these neck circumferences, even if you have no symptoms at all, you deserve a sleep study. The Berger-Link questionnaire asks a whole litany of questions, and there's this whole scoring process here, but it's basically asking the same things you're going to be asking people when you do an intake for sleep apnea. Okay, do you snore? Is your snoring light or loud? How often do you snore? Has anyone bothered you about your snoring? Like, hey, why do you treat this thing? You're bugging my sleep. Has anyone noticed that you quit breathing? How often do you feel tired? It's a very involved sort of version of what we just showed you with the stop bank. These are things you're going to be looking for in the practice. So as far as examination findings, you're looking for narrow airway. You're looking for anyone who's obese, even before you look in the airway, if your body mass index is above 35. If you've measured the neck circumference and it's greater than 16 in women, 17 in men. If you have a deep overbite or a narrow arched palate or a big tongue, those are things you want to look for. These are common symptoms that we just reviewed again. Nocturia is waking up to pee in the middle of the night. So most men, that's not a prostate problem, that's a sleep apnea problem. If you had a prostate issue, you have problems peeing all day long, not just at nighttime. If someone has insomnia, you're also looking for anyone who's got nasal obstruction, because if someone's got nasal breathing problems, they probably did not form the airway well as a child. So they're probably that patient that has an airway problem, not an obesity issue alone. An overbite, small jaw, large tonsils, if the uvula is very long, and if they've got a large tongue. So I want to give you some examples of some anatomical features you're looking for. So the tongue, when you look in the mouth, should be down here near the yellow line. As that tongue goes into the white line or higher, you have to push down the tongue to see the throat. Now you know that this is a big tongue for that patient's airway. It's likely going to relax and collapse on them. The uvula should be small. You shouldn't see much of it. But as it gets longer, it actually is probably becoming swollen from all the snoring, and that can be a problem. And then, of course, tonsils, if they're just a little nub here and an adult, and that's pretty normal. If you start to see the tonsil get even deeper into the canal or even over here, you know the tonsils are an issue. Oftentimes the soft palate itself will become narrower and narrower. So this in general, when I look at this throat, I can already see a small airway here, even though the tongue is only a lot mildly bigger. And this arch right here, you know, you're gonna look for a narrow arch as well. A very commonly referred to grade that you're going to be writing down when you're looking at airways is called the Mallampati score. This is used by anesthesiologists to see how hard it would be to intubate somebody. Class 1, someone opens their mouth and you can see obviously lots of space there. Class 2, it's kind of starts to be hard to see the back of the throat. Class 3, it's really challenging. Class 4, you're not seeing anything.
I would recommend that you do that without sticking the tongue out.
I agree too, or without the tongue depressor.
Yeah, right.
Initially, but if you can't see it and you use a tongue depressor, well, also it's very important. You can see, even though I can't see much of the tongue, I can see some scalloping here.
Right.
Scalloping by itself is a 70% predictor of snoring. So if someone opens their mouth and you see scalloping around the tongue, you pretty much, anything above 50% gives you the reasoning to do a test. Right. So this person just off the tongue right here, I would do a test, even if they were normal weight. Number 2, massively large tonsils. These are definitely 4+ tonsils, and tonsils are graded the same way. 1 is very small, 2 is medium, 3 is large, 4 is kissing tonsils. This person has kissing tonsils, and the uvula is also long because it's getting squeezed in between these tonsils and tongue, and it's getting yanked down between the apnea. So this person should definitely be referred for tonsil ectomy, as well as they probably have a small airway even when the tonsils are removed. So then an oral appliance will probably be necessary too, even once the tonsils are removed. And of course, what you see here too is a little bit of a wear pattern on these incisors here. You're probably going to see, you see some here on this bicusp, this canine here. So you're obviously going to want to put an appliance on that person for bruxing as well. And remember, most patients who brux are doing it because the airway is disturbed and they're working hard to breathe, and the teeth just happen to be in the way when you're trying to work hard to breathe and you're kind of gritting away at them. So if there is airway problems, it's very likely contributing to most, not all, but most bruxism. Just for some anatomical orientation here, the hard palate should be flat. The soft palate should not be very long in the throat. The uvula should not be very prominent. The tongue should not be sitting way high above the teeth. And this is what a good airway should look like when you are looking in the back of the throat. There are some procedures coming out that dentistry should be familiar with. There's the night lace procedure. It's a nice low risk, low invasive procedure where you're heating up the tissue versus excising it or removing it. And you can do it along the lateral borders here. You can do it along the central midlines here of the soft palate. And it basically causes the soft tissue to shrink. The procedure that's covered by insurance is called a uvulopalatal-pharyngoplasty, but we all call it UPPP or UPPP. And if you have a long uvula, crowded tonsils, a really narrow soft palate here, if you cut that away and then suture it together, you remove a lot of this tissue. Now, mind you, the tongue is getting pushed down right now, so the tongue's still a problem. And if you look here, that posterior airspace is very, very close to the tongue. There's no gap, there's no hallway there. So even though you remove this soft palate, this is still a very collapsible airway. And if this patient isn't wearing a dental appliance or doing positional therapy, they very likely still have sleep apnea, even though you removed all this tissue here.
I've seen that in my practice, Joe, and that posterior of the throat coming forward, that space is not being measured in any of the Friedman scores, the Mallampati scores, or pharyngeal scores. We need a new score, and that's the anterior posterior or dorsal ventral score.
Absolutely.
And that laser treatment, I do that in my office. It's called night lace. We use an erbium YAG laser. So if you want information on that, let me know.
Yeah, it's really cool. It's expensive and it's not covered by insurance. But again, say you start with a dental appliance, which has got the most research on it. The patient is better, and you want to give them options to improve their treatment. And you see some, not this bad, but some of this sort of sloppiness here. If you have one of these night lasers, you can do that in the office. It's a 10, 15-minute procedure. I think even without anesthetic many times.
Yeah.
And you might have to repeat it once or twice, right, Rick?
3 times per session.
Yep. So 3 times, and then that can shrink this tissue. And by treating this airway with the night lays and the lower part of the airway with the appliance, you could really help a lot of people that otherwise would be, not helped. Things you also want to look for is this wear pattern here. And look, this patient's got a pretty narrow upper arch here. You've got some crossbite here on the lower. That means that this is a poorly formed maxillary arch. Lots of wear pattern. This patient would have loved you if 20 years before this happened or 15 years before this happened, if you'd have had them on a dental appliance where they're snoring, which they likely have, their teeth would be a lot better looking. They would be working on their dental hygiene a lot better. They wouldn't have all these caries. There'd be a lot. This would be aesthetically a happier patient that had been with you for many, many years. So just know that by you doing this early in their life cycle, you're helping them have a healthier, happier, a more aesthetically pleasing smile over their life cycle. And the arches, we rarely see these arches anymore. Typically, you see this sort of arch. This is more like my arch. You have narrowing of the hard palate there. If you see this narrowing and crowding, you have a V-shaped jaw, and your tongue is a U-shape. So your tongue doesn't fit into the V. It's too crowded. So just know that that's something you're going to be looking for. If you see that, you can pretty much expect them to be mouth breathers and not be great nasal breathers also. And remember, you're also looking for crowded teeth. You're looking for a deep overbite, overjet, and you're also looking for an underbite, which typically has some crossbite as well. That means the maxillary arch is not very well formed, and this means that the mandibular arch is not very well formed. So just to give you an example of some non-CPAP treatments here, there's lots of different types of dental appliances that we can use out there. I'm a big fan of the Emma. It's the smallest. The bands are ones you can control as an office. It's one of the most affordable. It's one of the best studied. And because the bands do stretch out, there's built-in compliance where the patient's going to have to come back to you every year to get their replacement bands. Unlike the other devices where the patient can do a lot of the adjustment on themselves and sometimes get themselves in trouble. So just know that that's one of my favorites right there is the EMA device. There's also procedures where you can stiffen the soft palate with little inserts. There's also negative pressure, like a tongue retaining device. There was a device on the market called a Winx that's no longer in business. There is the Inspire, which is a new pacemaker that gets put to the tongue base, and that's turned on at nighttime, and it stimulates your tongue muscles at nighttime to help you with breathing. There's body positioners. Dr. Downs has the Snore device, which is, I think, the most affordable and easiest to use body positioner. This is a neck choker that vibrates on your neck when you're on your back. I'm not a big fan of it, but it is heavily marketed. The ProVent device is a PAP valve. So there's no machine to it. It's just the valve that you breathe against to cause pressure. They're no longer in business, but there is a device that we're recommending to use for that. And of course, there's many different devices. There's the Herbst, the TAP, the Emma, the Somnomed. There's some older devices, the Clearway, PM Positioner, Oasis. And there's actually ways to connect a CPAP machine to a dental appliance if the patient needs to get rid of the strapping or to combine therapies. So up until this last year, if you want pressure, you needed to use the ProVent device or a CPAP machine. And here's a machine, there's the hosing, there's the mask. Now there is actually an insert with no machine. It also goes inside the nostrils, and that's important because if the nose collapses, you can't breathe through the nose and you'll mouth breathe. So you want to increase airflow through the nose. So this was made to go inside the nose to make the nose work better, to inspire more freely. And when you breathe out against that little white valve there, it partially closes off to generate CPAP with every exhale. So you're making expiratory positive air pressure with every breath out. So you're the machine. You don't need a machine to be blowing into you. You make the breath yourself. So the reason why I'm suggesting this is, say I get a dental appliance on the patient, they're doing well, but there's still some residual snoring. There's still some apnea after we tested them. We can have them wear the dental appliance plus this little bongo to get a fully treated patient. So this is a big deal in dental sleep medicine. So I'm going to go through this a little bit more in our modules. This is an algorithm I put together years ago to go through the way to decision tree this thing for a dental office. And there's actually a video that describes this in depth on our modules for Sleep Balance Academy.
Yeah, it's in there.
Yeah, it's in there. So just know that this tells you exactly how to manage it from the first consultation to a sleep study to a follow-up to conservative treatments and CPAP or oral appliance therapy for the workup visit, the informed consent, the delivery visit, the follow-up, and then what to do if things are doing well or not doing well. We have a whole system that tells you how to do it. It's a very specific guideline-driven therapy. So once you spend some time learning it, there's no questions. And then what I want to do also is let you know that the ADA just recently has a position on sleep-related breathing disorders, or SRBD, or apnea. And you have to be aware that as a dentist's role in the treatment, dentists should, and this is a very important thing to understand. I'm hearing from a lot of lawyers now, the same thing happened when it became a should for dentists for oral cancer screening. If you have a patient that's seeing you regularly and they come up with oral cancer and you did not document that you looked at it in your general visits, you're now liable for not helping find and screen that cancer. So now that same thing is going to be applied to dentists that are not documenting that they're actively at least screening for their patients to have breathing problems, okay? So this is going to make it so that every patient realizes that you're doing this because the ADA says that to be doing the practice standards, you need to be screening for this because it's going to make a difference in your patient's life, well-being, quality of life, and their dental health. And this is what you're going to do. You're going to actually have a comprehensive medical and dental history to recognize symptoms of sleepiness, choking, snoring, witness apneas, and then refer these patients as needed to the appropriate physicians for proper diagnosis. Now, there's not enough sleep physicians in the world right now to do this. So your local sleep physician, if they're doing home testing, will be a good partner. If they're not, and they're doing in-lab testing only, it's going to take weeks or if not months to get them back. If you ever get them back, that's why you're going to want to work with our team to help you more quickly start to screen these patients with home testing, and we give you the interpretation and the prescription in those cases. You still try to reach out to your local sleep doctor, but there's going to be a lot more patients coming from your practice than what your sleep doctor can actually help you with in the end, okay? So oral appliances are appropriate for mild and moderate sleep apnea. If it's severe and the patient cannot tolerate CPAP, the dental appliance is the next best option. When oral appliance therapy is prescribed by a physician, so I have to write you a prescription, then the dentist is supposed to fabricate this and fit the device. The dentist should also obtain appropriate patient consent. And on our training modules, we go through an informed consent. Excuse me, we have a sample informed consent that you can use. And it basically tells you what's the problem, what are the treatment options, and what would happen if you do treatment, what could be the potential side effects. And of course, here at the bottom here, it talks about sleep testing, both home testing here. And it says a dentist trained in the use of these portable monitoring devices may assess interim results of the oral appliance. So titration is a fancy word for saying adjusting the therapy, whether it's a CPAP pressure being adjusted or a device jaw position being adjusted. That's a titration, means adjustment, okay? Just, it's a fancy word. And what you have to know there is that you could, as a practice, have a study, be trained to use it, give it out to patients, and use that in the follow-up process. And that's what the American Dental Association is condoning, is that you can actually actively do that as long as you have a sleep doctor doing the interpretations and giving you the
Joe and I are highly recommending a screening device called Circle Ring or pulse oximeter that is FDA approved for screening patients and also using it in the titration process. Joe, we got 10 minutes left. I want to introduce Kendra.
Okay, I'm on the last two slides here.
All right, go ahead.
So just to review here, the ADA policy statement, dentists are encouraged, and so that what that means now is that very soon, every dentist is going to need to do this if you want to be preventative toward legal tort, and that's what we all try to do. We want to give great care to our patients, but we also don't want to have needless tort issues with attorneys coming at us for not screening our patients. So this is very important. This will become the standard of care very soon. So the people that are there earlier are going to have a head start there. Refer to the appropriate physician once the patient has positive screening. So you need to have a way to do that. And so we're filling that void here with our group. So number one, start screening. All patients should have an update of their health history. Not some patients, not the patients you think you need to. Every patient that walks in the office should be filling out an Epworth score and a stop bank.
Right.
High blood pressure, type 2 diabetes, stroke, heartburn, atrial fibrillation, recent weight gain, if they have high alcohol use, if their body mass index is above 30, if their age is above 60, if they have bruxism, if they have scalping on the tongue, if they have grinding, if they have TMJ history, all those patients should have sleep apnea screening, okay? So now I've listed this, and if you're looking back at your information, your chart, you're gonna find at least half of your patients in your practice, at least half, need to be screened. So there's a big job here to do now that you're aware of it, okay? Just for some heads up here, this is an example of some of the resources we have here with Kendra and our team. We have actually super bills that have all the codes here, the appropriate procedures. And with home sleep testing, here's the appropriate diagnostic codes. And here's some of the questions that we can go over in the future when it comes down to actually helping you with medical reimbursement management here. So now we're going to open this up to Kendra. And of course, I'm sure there's going to be questions here for everybody. So feel free to shoot those questions at us, guys.
Yeah, thank you. That was great, Joe. Thank you so much. Kendra, want to say a few things? Are you still there?
I'm still here.
Okay, let me just change the view here so we can get you standard here view. All right.
By the way, guys, this presentation is recorded. So if you want to review it later on, you can review this later on. This is going to be a commonly used orientation presentation for dental teams, because if the dentist knows everything and the dental team does not know the process, it's not going to be implemented. We all have to have a certain amount of education on this process to actively implement this. So we really feel like the team is very, very important and integral to being a successful practice to implementing this.
Okay, Joel, can you release your screen?
Yeah, let's see here.
I can do that. I can do it. Maybe I can do it.
Yeah, why don't you try that as a remote control here.
All right, okay. I'm going to show you something here, and then Kendra, I'm going to have you kind of comment on this, because these forms, a lot of them come from Kendra, and I want her to understand. First, the physical evaluation form, Kendra, and can you all see that? Can you all see that form?
Yep.
Okay, so this is the physical evaluation that Joe was just talking about. We have a super bill and the physical evaluation, but you can see on this form that every time you go through a system, if you're doing you've done a screening and they have a situation where Joe had mentioned they need a physical actual exam for sleep apnea and an HST. First of all, you want to go through and check off this list. And each one has the ICD-10 code. This is the diagnosis code. Kendra, would you talk about that a little bit?
Well, first off, one thing that I would highly recommend in any practice is changing the medical history that you use, because the medical history that's generated out of dental software is definitely more dental related, and it really does not review systems. And when we're submitting exams and things like that, and when we're doing these things, we really should be segueing more into what medical wants, not dental. And we're missing too many things on a dental history.
Right.
It's not connecting the dots for the patient either, because patients always wonder, well, why do you need to know this? This has nothing to do with my dental. Well, absolutely, anything that they have systemically does have to do with dental. So that should be updated right away for starters, into something that reviews systems. When you're doing a head and neck evaluation, this is what helps prove to the medical insurance companies and helps with our documentation what we are doing. We're not just counting teeth. And this PE form is what establishes that.
Right.
If you're just counting teeth and you're not doing a full head and neck evaluation, then we don't submit exams to medical. But if we are doing a full head and neck evaluation and we're screening for sleep apnea, which this form will help you do as well, then this would be the form I'd implement into the practice as well.
As you can see, I've put your name on here, Dr. Barnett, at the bottom. And so you can, if you want to modify this form, you go right ahead and do it for your practice.
Awesome.
Okay.
And this is a very comprehensive form. I like this form a lot.
Yeah. And then the super bill, you can show the super bill here. I'm going to just bring that back up, Kendra, so they can see a super bill. I've done a couple versions of this. By the way, I've modified these forms and you can see that some of that, but this super bill, so helps. What happens when you do this? Like, I'm going to go back to the exam form. Okay, so you're going to write a SOAP note, Scott. And when I'm writing a SOAP note, I just grab this form and I go ahead and I start writing my SOAP note, and it goes right off of this, and off the super bill.
So something about that super bill that is really nice, and it segues into the super bill, is anything that's on that physical eval form, there are diagnosis codes, and that's the biggest gap between medical and dental right there, is the fact that we are never taught diagnosis codes in hygiene school or dental school. And in order to get any of our procedures covered on the medical side, we have to have diagnosis codes that attach to that. So the super bill allows you to have them right there handy, and it should segue into this super bill or this encounter form.
Yeah.
Whatever's on that, whatever's on that physical eval form for diagnosis should come onto this PE form, or PE, the super bill form, the encounter form.
On this left side, these are all procedure codes. This is what dentists are familiar with, procedure codes. And it goes up to this point right here. And from this point on, these are all diagnosis codes over here. Got it? So these are the most important things to the medical. You will be billing for these, and you have to have these to get paid.
Yeah, you have to have a reason for doing the procedure, and that reason is identified in the diagnosis codes. So that tells them, why are we doing these procedures? And you have to have them, or you'll never get a claim paid.
Right.
And down the road, to understand your relationship with the insurance company, Candra's going to be there and her team to help, navigate those, if you choose to work with us on that part of the service. We actually have a video on the Sleep Balance Academy that goes through an example of a policy, and we actually describe it in depth. So you're not confused when someone says, oh, you're denying services, or when they say, oh, we've authorized services, because they give you criteria very specifically that you need to complete to actually get reimbursement.
Right.
So these are things that we're going to be helping you with as a team. It's a lot to deal with if you don't have someone to help you as an extension to do that.
Now you can use your Sleep Bang in the hygiene room. It's a quick and easy form. I've developed this form. This form, the reason I developed this form is because I want to work with chiropractors and dentists together. And you can see all the necessary things up here. I need to add up here, Joe, is the irritability question. I think that is very important. I'll put that in here, okay?
Okay, great.
All right, so then you go through this. This is section 1, the medical. There's the Epworth score, which seems like insurance companies always want. And then down here are some chiropractic questions, but also some questions that will help dentists. And this is so quick. You can do this on every patient in hygiene, and it's very, very fast. If they get a certain score, you'll read it down here. If the score is 5 or more, they should consider a sleep study. And then you go to onlinehomesleepstudy.com. Since you're in Alabama, you can't order these things, but the patient can. So you can have the patient sit down at the computer, go to this site, and order their own sleep study. And they'll get one of those sleep study things that we showed you on the earlier slides. Okay.
Mhm.
Okay. Kendra, continue.
And I like having the Epworth and the stop bang. I find that those are the two biggest things that the insurance carrier wants to see is the Epworth and stop bang.
Right.
It really depends on the carrier, and I find that if I have both of them on the form, I like both of those screenings for different reasons.
Yeah, this is
Yeah.
pretty much stop bang
And
at the top.
yeah, so usually I have both the Epworth and the stop bang that covers us on a broad level
Right.
with most insurance carriers. And that's my thing on that.
Right.
But you do need that's one of the big things on global policies,
Right.
that when we talk about global policies, each medical carrier has a policy on when will we pay for sleep apnea treatment. And that's one thing that is the criteria, especially for a home sleep study, the Epworth
Right.
score.
So
Well, in this way, you should be able to meet that ADA policy statement now, just by including this
Yeah.
one form with every patient.
Yeah.
You could do two, you could hit two birds with one stone, you know.
that's exactly right.
It's such an easy form to fill out, to have the patient fill out. It's so quick and easy.
Yeah.
It's not hard to implement that into a practice.
And it tells you what to do at the end. So it's very simple. Okay.
Yeah.
So, and you can, after you get this done, you don't have to order a sleep study right away. You can put them on a circle ring and do another screening with your pulse oximeter. And I think the circle ring is the way to go, in my opinion.
And the circle ring, we have a video on that on the Sleep Balance Academy to go through that a little bit too.
Yeah. Right.
For screening. But essentially, it's an oxygen sensor that is in a ring format, and it also gives you a sleep graph. It's a great little way to see how people are doing, but that'll be outside this conversation, no question.
Right. You can find those on the Sleep Balance Academy site by just going in here, and you'll see the different things that you can get for your practice, the sleep studies, and also the circle ring is here. Dr. Zelf's consult for EPAP. So if you want to get a bongo for your patient, you can do it right here. And they have to have first a consult with Dr. Zelf, which is a $50 consult fee for Dr. Zelf. Okay.
And you know, the bongo is a prescription just like a CPAP, and so you need to have a consultation
Right.
Prior to a written prescription. So.
Right. Good. Guys, got questions? Come on, Scott, staff. I know it's late for you.
Yeah. I think it's a fabulous presentation. I think we have so many questions.
Yeah.
Can't really answer them. We don't have
Well,
time.
you have staff meetings once a week, right?
Well, probably we'll start that again at the start of the year.
Yeah, I think that'd be a good idea, guys, because I can't imagine my office not doing its weekly staff meetings. It's just absolutely essential, especially if you're going to start on something like this. There's a lot to get in order. All being on the same page, as one of your staff members said, all being on the same page is going to be necessary if you want to be successful. But the rewards are amazing, and the legal obligations are imperative. Okay, imperative.
I also wanted to. I gave a little homework for the team before this. We were supposed to be checking in with the two cases that were recommended just to get some follow through. Have we heard back from those patients on if they actually have seen the sleep doctor that were referred in the last few months, or no?
Oh, I don't recall it. It was the two. We talked about the two people that we actually had done appliances for. That was Searly. That's what you and I had spoken about, the two people that we had done the actual appliances for.
Yeah, we did too. There was two that were referred in the last few months to the sleep clinic, and then the two devices that were done. So, but if you got follow up on the devices, let's review that case real fast.
Okay, well,
Well,
Searly
see,
is,
she didn't show up. Did she? I didn't see her.
she's been coming. Is it Searly or Curly?
Either way.
And then the other one, we're waiting on a bite. The other one, we're not complete with her thing because we had to do a
We
bite.
sent it, they have it. The appliance. Yeah, Sonya Dale.
Okay, so this, yeah.
One of them, I didn't have anything to use to get a good protrusive bite and eccentric bite, but we've done that. And so her appliance is being made. And then Cyrily, she's just switched to a CPAP. I know that. She just went ahead and her name was on the schedule, but I know I didn't see her.
I think she just come in for a cleaning. Actually, I don't think it was for, I'll have to look at that.
And that's going to be, that one's going to be good because then you can check back to see if she's on a CPAP. Remember, most patients who have sleep apnea still brucks. So if she's on a CPAP, get her a bite guard. You know, if she doesn't have a CPAP, get her on a sleep apnea guard. The second thing that's going to really help you guys figure out how you're going to get your goals achieved for sleep apnea in your community is to follow up with those two that we talked about that were actually referred to the sleep clinic the last few months. See if they ever even followed up with the sleep clinic. Right. See if the sleep clinic actually even recommended a therapy. If not, that's why the Sleep Balance Academy partnership is so powerful, is we can start getting you guys comfortable screening. And then what do? You got to get them tested. And at this point in time, if we can get a home test done out of your practice, it'll be a fraction of the cost and a lot faster than just sending them to the sleep laboratory, which most studies are still running about $2,500 or more. An in-home test, like you saw on the website, could be a few $100s. And
our $275 on my test.
Yeah, $275 is, you know, delivered to their home, done within a few days, and then back for an impression in a device. Yeah. If you have a week and a half turnaround between you starting therapy and screening versus months, you're going to be a lot less frustrated.
Only thing it won't work for is Medicare. Okay.
Yeah.
Can't use it for Medicare.
Yeah, unfortunately with Medicare, you want to keep those two things separated. And if it's a Medicare patient, go through the standard process with your sleep clinic. Yeah. And you should be doing this because remember, if you're in Medicare, you went from the population of about 25% of general 30 to 60 year olds, and now above 60, it goes to almost 65%. So almost 3/4 of people that are in Medicare have sleep apnea. 85% of them don't know it. So if you're screening them, you're going to start finding this, and then you're going to start helping people live longer and happier lives too. You know.
Thank you.
And you know, when you talk about Medicare, you know, they have to see the sleep physician before you can treat them, right? Even for the HST. So many offices get nervous about developing that relationship with a sleep physician. And that's one thing I would not, don't be nervous about that. This works so well with that whole coordination of care and referrals back and forth, because there are so many patients that you know, fail CPAP. So many patients, probably more than do well with CPAP. Right. And they are going to send those patients to you if they know that you can take care of the patients and that you can bill them. Yeah. And with Medicare too, you need to know what your status is on Medicare. Are you participating, or are you a non-participating, or have you opted completely out? Because if you've opted completely out, you can't even submit a claim for the patient to Medicare.
No, we haven't opted out.
Right.
Sure of that.
Okay.
You're not opted out?
No.
Okay, so then you just want to know if you're opted in, like if you're non-par or participating, because there is documentation that you need to have in place for that.
Well, and then you have to apply for being a durable medical equipment provider. Yeah.
Yeah, you have to be a DME supplier. So that's a whole nother thing. But I just want you to be aware of it, because I don't want you to promise somebody that you can deliver them an appliance and then you don't get the reimbursement that you're looking for.
Right.
So does it matter that we are, I mean, like we file with Cigna and with Viva, and we get paid for, it's with their dental allowance. So is it something different other than that? If we are.
Yes.
Okay.
Yep. Completely different.
Okay.
And we can talk about that more from a billing perspective, but that is it's a whole different ball game.
Okay. All right.
So
but you can still go through the process, the learning process, screening, treating. Mm-hmm. You can still bill out of network while you're waiting to try to get in network. These are things you can do in the process. So don't feel like you're hamstrung if you're not in network yet. You can still get the process going. You'll be the best resource for this type of therapy in the area even prior to that, you know.
It's just Medicare that you have to be concerned about. If you're out of network, you can't bill it all to them. And with
But
DME
my
as
feeling
well.
is, yeah, my
But
feeling
still,
is
you want to still screen.
yeah, Medicare billing's probably going to be when you're feeling more advanced.
Yep.
Still see your Medicare patients, still give them a great deal. I heard that Scott's been giving some good starter deals here. Long term, we're going to have to increase that price a little bit.
What was it?
What was it? What?
That was not a true story.
Yeah. But yeah, you still treat them and you still work toward getting that relationship with Medicare officially eventually. But that's, you know, that's for more of when you're advanced. We can do a lot more screening and treatment even while we're getting ready for that too. And Kendra is the right resource for that too.
Yeah.
I think it's important that you target, you know, who are you going to initially target? Because obviously you can have everybody fill out screening forms, but as far as following through the whole process, I think it's important to set goals and targeting certain population. Wouldn't you think, Dr. Zelk? I mean, not that you want to exclude any patients, but so that you're not overwhelming your team, because there are so many people that need sleep appliances or that need HSTs.
Mm-hmm, mm-hmm.
Like your whole practice all of a sudden becomes encompassed with just that.
Well, if you start looking, it's like it's, you know, you're going to find people, and I think you're absolutely right. Rick's actually absolutely right. You give them that little screening form. I would give every patient that screening form, have them fill it out, and then as you're seeing them, people just get in the habit of just kind of glancing at that score at the bottom. Yep. Just glance at the score at the bottom, and then gauge their reception. How receptive are they to it? You know, if you see all this massive wear on the teeth, you might as well do a sleep apnea appliance, because it's going to both protect all that work you're doing. If you're doing implant cases, you need to protect those teeth from all that massive parafunction that's happening, right? If you've got headache patients, if you've got sensitive teeth patients, you got to get them on a retainer of some sort. Why not get one that's actually going to get them breathing better and protect the teeth at the same time?
Right.
You know.
Exactly.
So what's the definition of failed CPAP? Like, we have a lot of people we've sent.
They're not wearing it.
And
They're not using it.
They're not wearing it.
So there's a couple of definitions for that. The first one is if they're using it and they're still symptomatic, okay? If they're still symptomatic, that CPAP is affecting their sleep process, and maybe the pressure's too high, maybe they need to go a lower pressure. That's a great patient for trying a dental appliance to lower the pressure, and the combination can make them feel less symptomatic.
Yes,
that's one way.
My question is, what does the insurance company see as a definition? So they'll pay for an oral appliance after they've just paid for a CPAP.
So the primary one is less than 4 hours. I'm sorry. Yeah, less than 4 hours a night, 5 days a week. Okay. If they use it less than 4 hours a night, 5 days a week, that's considered insurance compliance. Okay. That's textbook. But over time, if they're still using it 4 hours a night, 5 days a week, and they're tired, no one's sleeping 4 hours a night. Okay. No one sleeps 5 days a week. You know, there's under treatment there. So the slam dunk is the first scenario, and you can eventually get these other ones covered down the road.
Yeah.
Or if they're not using it at all, and that's the obvious one. If they don't use it at all,
and
you know.
Yeah, and just filling out the intolerance form is usually enough documentation.
That's right.
For the insurance carrier.
They just have a patient.
And that's a good point. We didn't show that form, but there is a CPAP affidavit that says you're intolerant to CPAP as a patient.
Right.
Well, and like Dr. Zelk said, the intolerance form, and then the diagnosis is still excessive daytime sleepiness. Patient is still showing signs and symptoms of not being controlled.
That intolerance form has been integral for oral appliances to become part of insurance coverage since the beginning. When we first started doing this, no insurance would cover dental appliances. And then no insurance would cover dental appliance unless you had failed CPAP with an affidavit, whether you're mild, moderate, or severe. Right. And now, luckily, the guidelines say that mild to moderate, you can go directly to it. But I still have patients fill out as many forms that are appropriate for them. You know, it just helps the ball roll smoother.
Exactly.
Yeah, these are, I have my offices tend to have a folder already pre-assigned with all of these forms in them so that none of them get missed.
Right.
And they pull out a folder and they make sure that every one of those documents is signed along the way with that patient.
Yeah, you need to check
They're
both of
just,
those.
yeah, or if you have an electronic system like Yappy or something like that, you have a designated area with all those forms in it, and we make sure that they all get taken care of, because those they're just the standard, the gold rule, what we need.
I can tell you that if you're not tracking your
Yeah.
patients on some kind of tracking, you'll know, you don't know if this one's ready for HST, if this one's
Yeah.
been submitted. It's like, it's a nightmare. You've got to have this tracked on some kind of spreadsheet, or you'll lose track of these patients.
What do you recommend, Kendra, for organizing that for these guys?
Well, for the most part, I mean, I use a Dropbox and we have folders set up. We do an initial snapshot. That snapshot is done. We move it to it's completed. Now they know that the patient's, ready to move forward in the process.
Yeah, I can show that
They
too.
could add, they could add to that.
Yeah.
That makes it easy and online
Much
and
better.
shareable between
Right.
me as a biller and them.
Yeah.
And
Typically
actually
by the
goes
time
on site if needed to do the training, or she can support you guys remotely as well if you feel like you need the help. And a lot of offices, the primary thing is hey, we want to do everything appropriately. We also want to be able to try to get the best successes participating in this insurance thing as possible. And it's getting harder every day. If you do not have someone who's experienced with this, you might as well just be charging cash. I'm telling you, it's getting challenging. Deductibles are wildly higher than they were when I first started this thing.
Right.
When I first started back in 05, it was crazy to see a deductible over $200. Nowadays, it's not uncommon to see it over 2,000, 2,500, 3,000, and you'll still have to, tell the patient, yeah, it's covered, but you're going to be paying for all this until it hits your deductible. You need to know that. You need to know whether it's,
Right.
You need to tell your patient these things.
Right.
Right. And when we talk about deductible, so there's in-network and there's out-of-network deductible. If you're not in network, if you're not enrolled, you're out of network, and you need to understand, and we need to fight for the patient to get what we call a gap exception. And a gap exception is basically pay us for this procedure this one time with this patient. Because it definitely minimizes their out-of-pocket expense. Not that we can control their deductibles, but say if their deductible was, say it was $5,000 for in-network, it's going to be at least 10 for out-of-network.
Mm-hmm.
And that's going to be really hard for them to achieve, because most people see in-network providers. They know that from a medical perspective, they want to see an in-network provider.
And that's great for their location because it's a smaller community in general, and you guys are pulling from other areas, and you're more likely to get a gap exception. If you're in the middle of Portland, there's a ton of people that provide oral appliances. You're not likely to get a gap exception. They're going to say, go 10 minutes down this way to this guy, But in your area, very, very likely.
And sometimes, Dr. Zelk, if the patient, sometimes we have to enroll the patient in that process, like in larger metro areas. We can get the patient saying, you know what, I want to see this provider, because not every provider is created equal when it comes to this treatment. And so I want to see somebody that I'm comfortable with, I have a relationship with, and that I know has had the training to give me the best possible care. So sometimes the patient can wiggle the pendulum on that.
That's a good point. That's a good point.
Say something about the TMJ codes, please.
What I sent you in an email?
Yep.
Okay, so the super bill that Dr. Downs showed you, I have changed that because what I was seeing is many providers would put TMJ diagnosis codes on that super bill. And if we put those into why we want a sleep appliance, or why we want even a home sleep study, that muddies the water, because many global policies say they will not cover sleep treatment of any sort if there's TMJ related problems or periodontal disease. So I'm very cautious to not even have those integrated into a super bill. The TMJ diagnosis codes integrated into a sleep super bill.
That's important.
Because many providers, yes, they do overlap. And it's important for you to know, do we have a TMJ issue or do we have a sleep issue?
Yeah.
It's good for you to know, but it's important for you to know the global process of this. They're not going to cover anything if a patient has a TMJ problem.
Yeah, insurance companies are using outdated thought processes.
Right.
When oral appliances
Yes.
first got approved, they said, oh, TMJ is contraindication, which we know is bull. But there's a lot of, most temporal mandibular disorders are muscular and hyperactivity. If you get them breathing well, you're gonna actually control that much better.
Right.
And because that was mentioned long ago, they're not relinquishing that, you know, so you can't give them something easy to
lie
deny
about it, just don't mention it in your soap notes.
Okay? Yeah, you can have a note in your, you know, that the myofascial pain is due to the sleep apnea,
there you go,
you know, and the bruxism or whatever, but we don't want to give them the diagnosis codes that are going to lead to a denial. That's what I'm saying.
Yeah,
so
I think the codes
unfortunately
misconstrue it.
And unfortunately the medical global policies and the medical in general, they're probably 15 years behind on their research on this kind of stuff.
Right.
Unfortunately, that's what we have to still work with. So
I see your staff has left, Scott. So
we're too long in the tooth there.
We went a little overtime. I do hope that that's helped a little bit. I think we could go on forever on this, and we're probably going to need to close it up for you guys. So
I appreciate this very much, though. This was fabulous.
all right, thank you, Scott. I'm glad to know that.
Hopefully the team now realizes these type of resources are available now at their own leisure on Sleep Balance Academy.
Go through the modules with your staff.
As the leader of the practice, keep pushing the modules. I want to encourage you to download that screening form and have the team start implementing that right away.
Yep.
And like I said, you need to review these things in real world. We're mentors here for you. So I would follow up on those couple of cases that were referred to the sleep lab, and you can email or have one of the team members email us on those cases, and we can help you follow through with that stuff.
Thank you. Thank you, Joe. Thank you, Kendra.
You bet. You guys have a great rest of your day.
And Colette says hello to you, Scott.
Sir?
Colette says hi.
Oh, hey,
well,
I haven't seen her in too long.
Yeah.
Well, wait a minute. Am I chopped liver or what?
No, well, you feel of course. Yeah, I'm telling you, I'm really proud of Kendra. She had surgery, yesterday?
Wednesday.
And she's on the line with us today. It's just amazing to me. So thank you.
Yeah, well, yeah, absolutely.
All right.
I love what I do, so it's easy.
Thank you, everybody.
Thank you very much.
Have a good weekend.
Thank you, guys.